je garde ma caméra ou bien non, Ibrahima?
Vous pouvez ne pas garder. Laisse la caméra. Fermez la caméra maintenant.
Je ferme la caméra. Ça me fait les états.
Ok, fermez aussi le micro. Voilà, fermez aussi le micro aussi, s'il vous plaît. Rachid, fermez aussi le micro.
Je laisse mon micro, Ibrahima.
Fermez, fermez. Fermez aussi.
Ferme le micro. OK.
Hello, everyone. I am happy to present my talk in this international conference. I am Professor Mahsoun Zalimi from Faculty of Medicine, University of Kufa, Najaf, Iraq. I would like to present a talk of laser-assisted transepidermal drug delivery in dermatology. I have no conflict of interest for this talk. Direct application to the skin remain a favorable method for treatment compared to systemic therapy. Stratum corneum found to be the toughest barrier to chemical agents and drugs applied on the skin. It is found that only 1 to 5% of topical preparations can cross the intact epidermis. So, overcoming this barrier is one of the important challenges that faces dermatological drug developers. Strategies to improve drug delivery can be broadly subdivided into chemical, biochemical, or physical approaches. Previously, there are many methods used to overcome this barrier, including the tape stripping to remove the stratum corneum, electroporation, ionophoresis, microneedling, and ablative lasers. Laser-assisted drug delivery is now an increasingly interested subject and an increasing number of published articles dealing with this issue. It was first established in 1987. The primary concept of this method is to facilitate increased topical absorption commonly through the skin. The commonly used procedure is the administration of laser to the area to be treated. This is followed by topical application of the therapeutic substance. Lasers are able to physically disrupt the skin barrier in order to increase the permeability to such substances. The fractional lasers are commonly used for this methods as they create small micro openings that are called microthermal zones through which the applied substance can penetrate more freely into the treated area. Actually, both the ablative and even the non-ablative lasers can increase the drug penetration. These methods have been studied in the management of various skin disorders, including melasma, vitiligo, alopecia areata, actinic keratosis, non-melanoma, skin cancer, scars, and photo damage. And it is found that this method is more favorable to systemic administration of the drug. Several medications have been utilized in this technique, including, for example, hydroquinone, tranexamic acid, kojic acid, corticosteroids, minoxidil, photosensitizers, and immunotherapy agents like imiquimod or 5-fluorouracil. The laser-based approach sometimes induces thermal damage to the skin, and this may induce the post-inflammatory hyperpigmentation in a treated area. And this is very bad side effects, especially when we're treating melasma. So you have to give very low controlled powers and frequencies of the lasers when used for this method. We apply lasers with low power and low fluence just to make openings in the stratum corneum. The first work done by our group is the evaluation of the efficacy of a fractional erbium YAG laser-assisted drug delivery of kojic acid in treatment of melasma. It was a split-phase comparative clinical study. We aim to compare the effect of kojic acid alone and when accompanied with application of erbium YAG laser. This study was a single-blinded, interventional, comparative, split-phase study performed in the laser research unit in our faculty. 32 patients diagnosed clinically with melasma were enrolled. Inclusion criteria were patients having bilateral melasma with different facial involvement. Patients haven't received treatment for melasma in the last 2 months, apart from topical sunscreens. Those with type 6, history of skin malignancy, history of keloid, history of immune compromisation, history of chronic systemic disease, and females on oral contraceptive pills, pregnant and lactating women were excluded from the study. All of the patients were female. Different treatment protocol assigned to each half of the face. One half was treated with erbium YAG laser, which was ablative mode, fractional, 9 millimeter tip, pulse duration 0.3 milliseconds, frequency 4 Hz, fluence, very low fluence of 0.3 joule per square centimeter. The patients also instructed to apply kojic acid 1% cream daily at night on both sides of the face throughout the study and follow-up period. Evaluation, either objective by mass score, calculated at the baseline and 2 weeks after the last session, and also photographic assessment for visual analog scale of improvement, which was performed by 2 dermatologists not involved in the study. Subjective methods, evaluation of the patient's satisfaction. Results from these 32 patients, we have only 25 patients completed the treatment protocol. All patients were females and their ages range from 20 to 52 years. Duration of melasma from 3 months to 10 years with a mean of 2.2 years. So they are present for a long time. All patients have skin type 3 and 4. Both sides actually showed significant improvement, but we compare between these two sides, there was no significant difference in improvement between two sides. The mass score at the baseline was the same, 12.1 on both sides. It reduced to 8.5 in the laser-treated site and reduced to 9.4 in the kojic acid-only treated site. Although the reduction is more on the laser-treated side, but the difference is not significant. On visual analog scale of the photographic assessment, also there is the excellent and good improvement is more on the laser-treated side, but still the difference is not significant. Patient satisfaction, also we get excellent and good satisfaction more on the laser-treated side, but also the difference statistically is not significant. These are photos of some patients. The upper photo for the laser-treated side, and we see improvement on both sides. Apparently, it is more on the laser-treated side. The same found in this patient. Regarding the post-treatment adverse effects, no serious side effects were detected on both sides, apart from mild redness and irritation that was resolved spontaneously within few days. We make a follow-up study after 3 months, and this is important because the most important thing is to prevent recurrence of the disease, as the melasma is chronic recurrent disease. And we see that the MAS score is slightly elevated at the 3 months after treatment, but not return to its original score. So we cannot maintain the treatment after stopping it. In conclusion, we found that this combination of erbium laser and kojic acid is effective and safe at the same time in treating melasma. In another study done also in the same center, we use non-ablative laser of erbium YAG laser in fractional mode for treating alopecia areata. It is an interventional, case control, single blinded comparative study done in the Laser Research Unit in Faculty of Medicine, University of Kufa, Iraq. 35 patients were enrolled in this study. 5 of them were lost during to the follow-up. So we have 30 patients with 2 patches of alopecia completed the study and follow-up period. 18 patients were males and 12 patients were females. The alopecia areata diagnosed clinically, and the selected patients should have at least 2 patches. 1 patch was treated by laser and minoxidil as the study patch, while the other patch
Hello
was
everyone.
kept as a control patch and
So we
treated by
cannot maintain.
minoxidil solution only. Inclusion criteria, as we say, patients should have at least 2 patches. Duration of the disease should be not chronic, up to 3 months. Not received any previous treatment in this period. And for easy application of the laser, we choose only the scalp and beard area. Photograph was taken for each batch for comparison with subsequent photographs. The laser system used was the non-ablative fractional 1540 nanometer erbium glass laser from Quanta System Company from Italy. The parameters was the flat tip, 1 Hz frequency, 7 milliseconds pulse duration, spot size 8 millimeter, energy as 8.1 millijoule, and 440 joule as a total energy with a 300 micrometer estimated depth. The provided pulse energy per unit area for each patient at each session of the treatment was the same. The whole patch was treated in a sequence with 2 passes, vertical and horizontal. All patients were assessed every session for any adverse effects like itching, scaling, and erythema. As we say, all patches in group 1 underwent 6 sessions of laser therapy at weekly interval, in addition to topical minoxidil solution twice daily for 6 weeks. While in the group 2, the batch treated only with minoxidil solution twice daily for 6 weeks. All patients were instructed to return for follow-up after 6 weeks of the last treatment session. The evaluation including the hair count evaluation by assessing an identified area of 1 by 1 square centimeter by the photographic follow-up of this area. Also, we evaluate the percentage of hair regrowth in the treated area during the treatment and follow-up visits. This evaluation done by also 2 board certified dermatologists not involved in the study and classify the improvement into 4 categories. Subjective methods, patient satisfaction on a 10 points scale. Results, 30 patients completed the study. Their age range from 10 to 40 years. This table shows the improvement in the hair count. The hair count in the study batch increased from 8.4 to 9.3, but increased more even after stopping the laser treatment at the end of follow-up period into 10.9 per square centimeter. And the difference found to be statistically significant. While in the control patch, there is no more increase or very little increase in the hair count, and the difference was not statistically significant. When we compare both groups in the pre-treatment, of course, it is not statistically significant, but even post-treatment, the difference is still not statistically significant. But at the end of follow-up period, there was great difference, which was statistically different. Regarding the hair density in the treated batches, also there is no difference in the pre-treatment period. And in the post-treatment, also there is no significant difference between the 2 batches. And at the follow-up period, there was a statistically significant difference. Within each group in the study batch, the difference is statistically different, while in the control batch, the difference is not statistically different. These photos show very clear difference. This is the laser-treated side. We see here very significant hair regrowth, while the hair regrowth is not significant in the side treated with minoxidil only. Also, we here see regrowth of the hair in the laser-treated side with less hair regrowth on the minoxidil only treated side. Patient satisfaction also improved on the laser-treated side, especially in the follow-up period. No significant adverse effects were developed in the laser treated site. They were simple and transient. So in conclusion, erbium glass laser seem to be effective in regrowing of the hair in alopecia areata. What is most important is that the persistence of durability of the effect even after stopping of the laser sessions. The possible mechanisms, in addition to increase the transepidermal penetration of minoxidil, it may leading to stimulation of the hair growth by increase the temperature in the affected area or through an immunological effects on the hair follicles. Thank you very much for your listening.
Good afternoon, ladies and gentlemen. I'm back, and this time with a different topic. I'm going to speak to you about skin boosters, the art and science. I think um, I'll be failing in my duty if I do not tell you that skin quality is the future. It's something that we're speaking about at all global conferences. We're not only trying to lift and fill and firm the skin, but also focus on skin quality, giving patients that elusive glow and giving patients back radiance, which also makes a lot of difference. So here are my conflicts of interest. The current presentation is non-aided and non-funded by any organization of pharmaceutical concern. So when we talk of boosting one's skin, I want to boost the skin's anatomy in terms of elasticity, collagen, and I want to boost the skin's function. I want to give it hydration and firmness, and maybe, like I said, the elusive glow, which amounts to skin quality. Now, I'm talking about redensifying the skin, revitalizing the skin, rejuvenating it, and refreshing it. Those are my aims from skin boosting, and not the periodic table. If you thought I was confusing you. If I expand the spectrum, how have we treated skin quality till now? We've used non-ablative lasers, we've used energy-based devices, skincare to some extent, collagen, and hyaluronic acid, which forms the mainstay of expanding the spectrum when it comes to skin quality. Why hyaluronic acid boosters? They bind 1,000 times their weight in water because of because of the hygroscopic nature of hyaluronic acid. That's why it's called the youth elixir. So it's relevant physiologically. But even anatomically, it's the most abundant dermal glycosaminoglycan. It forms a framework of the extracellular matrix, and that is why hyaluronic acid is anatomically relevant as well. Why injections? Every molecule that we apply on the skin has to follow the 500 Dalton rule. If it's over 500 Daltons in weight, it has to be pushed inside. But if it's under 500 Daltons, it can easily penetrate, which is why injections make sense, because hyaluronic acid is a heavy molecule, kilodaltons to be specific. So it needs to be injected at the target area. Size is also important. Most of the boosters that I show you today, which are hyaluronic acid based, are multimolecular, which means they have a low molecular weight HA and a high molecular weight HA. Both have their own things to prove. One is anti-inflammatory, the other promotes angiogenesis, which is why both molecular weights are combined. So again, there are studies which show that once you stretch the skin, that turgor itself stimulates fibroblasts to produce more collagen, which causes collagen remodeling. So this is actually useful in collagen induction, maybe a tad less than an energy-based device or a fractional laser, but definitely something which more than meets the eye. Which is why just by simple hyaluronic acid boosters, also our patients are able to get improvement in pigmentation and evening out skin tone, which means some sort of pigment dilution or an indirect pigment control does happen when we stretch the skin with skin boosters. So I'm going to talk to you about the purebred ones, like the two cute puppies you can see in the photograph. The pure HA ones, because apart from that, you have HA combined with toxin, antioxidants, glycerol, cellular factors, and such. But my discussion today is going to be limited to pure hyaluronic acid-based boosters. And also I'm going to introduce polynucleotide fillers, which we've recently started doing. So in terms of skin boosters, the three things I'm going to look for are stabilization, cross-linking, and HA concentration. Cross-linking simply means how much of your HA can resist enzymatic degradation in the dermis, which means I have long-chain hyaluronic acid fragments. I either let them coalesce on their own, or I bind them covalently with something known as BDDE. So all of you know, depending on whether you're using Juvederm or the Restylane range, Restylane uses a very low cross-linking product. But when it comes to Juvederm, they use a lot of BDDE. But again, those are all semantics. What matters is how much of the product is covalent, how much of it can resist covalent bonding, and how much of it is cohesive. So ideally for a booster, I wanted to have high tissue integration. I wanted to integrate with the tissue the minute I inject it. So I want something which has low cohesivity, but more on that later. HA concentration, like I said, is one part of the story. But if you look at buying cameras, this is more like buying cameras for a megapixel. Unless I want to blow up a photograph, I'm not really interested in megapixels as such. But how much of it is cross-linked is actually much more important than the actual HA concentration. So mark my words, it's controversial, but that is the truth. Rheology is always something I'm very fond of. Anatomy, rheology, these are the two things I always do when I'm training for Allergan, Galderma, or Menarini. So essentially, you want your product to behave like a solid. That is a marker of G prime. How much of it behaves like a liquid, that is G double prime. And how cohesive it is. The more cohesive my product, the more it's holding its own in the dermis, the less it will integrate with my tissue surrounding. Whereas in a skin booster, I wanted to be low. I wanted to have a low cohesivity, but integrate with tissue much better. So my boosters are low G prime, high G double prime, low cohesivity, high tissue integration. So I'll repeat that again for you to understand. Low G prime, I wanted to behave less like a solid. High G double prime, I wanted to behave more like a liquid. Low cohesivity, I wanted to hold its own, but a little bit. But most of it, I wanted to integrate with the tissue. So high tissue integration or tan delta. So this is what we have. Volite 12 milligram per ml HA, partially cross-linked. Filderma 16 milligram per ml, again partially cross-linked. Vital 20 milligram per ml, partially cross-linked. In the US, you have Vital Light, which is again 12 milligram per ml cross-linked to match the Volite from Juvederm. And then you have Profilo, 32 milligram per ml into 2 ml, so total of 64 milligrams. This is non-cross-linked and a very high tan delta. PDRN-based fillers again have polynucleotides, which are derived from salmon sperm, but they also have hyaluronic acid, which is non-cross-linked, along with glutathione and other additives. So these two are non-cross-linked, which means high tissue integration. You create blebs on the top and they'll integrate with the tissue on their own. That is the fundamental of a high tan delta or high tissue integration. Whereas with Volite, Vital, and Filderma, you need to inject at the deep dermis, not create a bleb so that it integrates properly with the tissue. So this is the same thing I've told you, injection strategies. With Profilo, go very superficial, create a bleb. With PDRN, go superficial, create a bleb. With the other boosters that I spoke about, go deep in the dermis and then inject so that they reach the target depth. So I'm just showing you levels here. On the left side is Profilo. You can see a nice big bleb sticking out of the neck. Whereas on the right side, I'm using a partially crossing product. So I'll respect the product because it is cohesive. If I create a bleb, I'll cause lumping. So I'm injecting it full bevel in at the deep dermis. So I'm just quickly going to show you videos. This is a 10-minute lecture. I have about 4 minutes left. I want to be able to drive messages across. So in the first photograph, I'm injecting Profilo. You can see I'm creating a visible bleb. Let me quickly come to the end of the video so you can see that bleb, beautifully created bleb. My product will do the rest because this is non-cross-linked hyaluronic acid. And I'm also treating up prednismal bands with a botulinum toxin in the right side. So good combinations. So these are pre and post. A little bit of filler I've added to the DAO area, the depressor anguli oris, because she had an asymmetric smile. You can see great results pre and post in terms of glow and symmetry. This is Juvederm Volite. I'm going to go half bevel in, roughly 3 to 4 millimeters inside the deep dermis. Coming out, injecting again, you can see no bleb, very clean work. This is what I want with a partially cross-linked product. Again, pre and post results. You can see good evening out of the skin tone. This is something which I had done as an off-label indication, where I had a patient of atopic dermatitis, and this was when Volite was just launched in India. And you can see I did his forehead, the perioral area, and we used almost 4 ml for this patient. And atopic dermatitis being a clinical indication, I was something where he was on cyclosporin and a lot of topical moisturizers, but I wasn't able to get his barrier control. He was very happy with the itch control for AD, but not very happy with barrier repair. So we did Volite for him, and voila, pre and post results, fantastic. This is life-changing for the patient. And the hydration component lasts for about 9 months. So this patient comes to me once in a year to get this done. Again, Filderma Revitalize, partially cross-linked, 16 milligram per ml. This comes with a nifty 34 gauge, 34 gauge 4 millimeter needle. So I'm going full bevel in, deep dermis, no blebs. Again, good pre and post results, good evening out of the skin, and improved skin texture if you look at the malar area. Nucleoskin is a PDRN booster which we have in India. I use it undiluted for the face and neck. I'm going to show you. It's done by the same bioaesthetic point technique that we do Profilo with. So this is the BAP technique in a patient. And for the tear trough, you can do an additional 1 ml, which is diluted 1:1 with normal saline. This has polynucleotides, which is salmon sperm derived, like I said, non-cross-linked hyaluronic acid, and glutathione. Again, you can see good pre and post results. So polynucleotide fillers are also very, very good for skin texture. If you see our static lines on the forehead and the periorbital area, you'll see the difference. And these are 2 sessions apart, done at 3 months interval between the two. So how do I use them? I use them for aging skin, for patients who are not comfortable
La
with
diffusion
fillers,
en
for
direct
giving them
s'est
that elusive
arrêtée.
glow. Younger patients coming in asking for glow. This is a great thing to do. Barrier repair in atopic dermatitis and topical steroid damage facies. So you can use it for clinical indications. A lot of my patients fly in once a year. They get energy-based devices done, fractional lasers done. I use it as a cherry on top for those patients. I also touch it up with harder fillers. So for example, if I've done the tear trough with the patient who has a little more bang for her buck, I can do a superficial. So if I fill the SOOF with a moderate G prime filler, I can do this on top, just to kind of smoothen out the fine lines over and above without causing any filling. Same for the lips. So with any dermal filler or booster, less is more. Start with a low quantity, 2 to 3 ml is what I usually do per session, and you can always touch it up if the patient is not happy. I use it on the face, neck, décolletage, and the hands. Vascularity is important. There have been reports of vascular occlusion even with partially cross-linked products, which are 12 milligram per ml. So be careful. Always respect anatomy. Know when you're going very medial. Know when you're over the angular artery and the dorsal the dorsal nasal artery. Dangerous areas of the face. Respect them properly. When you're doing the forehead, do it with caution. But otherwise, skin boosters overall are much safer than dermal fillers because they're low G prime. All skin types can benefit from skin boosters. I always assess in the same way I assess for fillers. It's always my aesthetic judgment over everybody else, over everything else that they get me from the internet or Instagram. Aftercare is pretty much the same as dermal fillers. What all can go wrong? Erythema edema, which is transient, beading, lumping, nodularity can happen. Tyndall effect can happen along the tear trough if you're too vociferous or if you've injected a big bolus instead of giving microalicot. So be careful with your product. Always know your rheology, know what you're injecting. Bruising can happen obviously in the under eye area and the lips. HSV reactivation, iatrogenic infections, granuloma formation, these have all been reported. The limitations right now to hyaluronic acid are every company seems to tell us that their HA is better than the other companies or the competitors. So always choose your HA products wisely, test everything in your clinic, see what works best for your patient skin types, your patient profiles, and what satisfies your patients more. Always have an objective assessment which you do at the clinic. It could be simple photography or line counting or something through Vizia or a clinical software. Longevity is again a problem. We don't know how long they last. Some companies say 6 months, some say 9 months, and we don't have an objectivity on how many sessions to do and at what intervals to do that. But ladies and gentlemen, I really feel skin quality is the future. Always be rheologically correct. Know what you're injecting and at what depth you are. Align expectations with reality. Undercorrect and inject again if required, and always underpromise and overdeliver like you would do for any aesthetic procedure. Thank you very much for a patient hearing. I know I sped through my slides today, but any of you have any doubts, do hit me up. I would love to tell you about skin boosters. I love them to the core, and I've been doing a lot of them in the last 5 to 6 years. Thank you very much, MDAS and Basil, and I'll see you guys soon. Thank you. Take care.
Hello everyone, I am Dr. Mariam Rouhei from Tunisia, and it's a great pleasure for me to be part of the speakers at the Guinea World Skin Health Day Congress. I will present to you 2 clinical cases, and we will start immediately with the first case, which was seen by Dr. Khalid Turki and myself. This is a 31-year-old woman who had multiple millimetric flesh-colored, dome-shaped, firm and smooth-surfaced papulonodular lesions topped with fine telangiectasia, evolving since pre-puberty in the central part of the face, forehead, periocular region, nasolabial folds, perioral region. They were aesthetically disturbing, and her father had similar lesions. We performed a skin biopsy, and pathology reveals trichoblastoma. To treat this patient, we thought of some alternatives. Surgery would have a poor aesthetic outcome. The problem with electrocautery is the lack of control of the coagulation depth, leading to high risk of scarring. PDT is hardly available in Tunisia. Pharmacological treatments such as imiquimod, sirolimus, and vismodegib are also hardly available in Tunisia, and given the thickness of the lesions, they would be ineffective in monotherapy. The best alternative was laser therapy treatment, and in this case, we chose a continuous CO2 laser. We performed a continuous mode CO2 laser, one session under general anesthesia, using power ranges varying between 10 and 20 watts in focused mode to ablate the lesions, and defocused mode for smoothing and homogenizing the skin. Here we see the immediate postoperative aspect. Postoperative care consisted of the application of Vaseline dressing and fusidic acid ointments. At day 20 after laser, we observed a partial improvement. 2 months post-laser, we observed a partially satisfactory result. Certainly, the number of tumors has decreased, but she still has lesions that may justify a second session. Also, she keeps this chromic sequelae, such as hypochromic areas at the level of the upper lip and chin, and hyperpigmented macules at the level of the cheeks. She was put under depigmenting cream. 7 months later, the hyperpigmented lesions began to fade. The patient was satisfied, and a second session is scheduled. We move on now to the second case. This one is from Dr. Rachid Hamlewi, whom I would like to thank warmly. So this is a 20-year-old woman who had multiple dome-shaped papulonodular lesions since childhood, similar to those of the first patient, causing aesthetic discomfort. Her mother and maternal aunts had similar lesions. A biopsy done 2 years ago showed trichoepitheliomas. The patient therefore received a single session of erbium YAG laser with the following parameters: a fluence of 50 joules per square centimeter, a pulse time of 0.6 milliseconds, and a frequency of 8 Hz. Here is the immediate post-interventional result. Postoperative care was done with a wound healing ointment. At 2 months post-laser, we observed the disappearance of almost all of the lesions with residual hypochromia. The patient was nevertheless satisfied. Multiple trichoepitheliomas appear as round, smooth, shiny, slightly translucent, firm, and millimetric circumscribed papers or nodules with small telangiectasias, and a center that can be slightly depressed with symmetrical arrangement in the upper lip, nasolabial folds, and eyelids. Other possible locations include the skull, the neck, and the trunk. The onset is generally during childhood or adolescence. A female predominance is observed. At the dermoscopy, we can observe arborizing vessels schematized by red arrows, pseudocysts schematized by black arrows, arborescent vessels within white structurous area schematized by blue diamonds, and pseudocysts within white structurous area schematized by black circle. The diagnosis is confirmed by the pathology, which shows several nests of basaloid cells, some of which show aborted follicular differentiation. Stroma resembles the fibrous sheath of normal hair follicle. Fine collagen fibers and fibroblasts surround the tumor's island in a concentric network. Brooks-Pigler syndrome is a rare genetic disease of autosomal dominant inheritance due to the mutation of the TIL gene characterized by the presence of familial multiple trichoepitheliomas, with possible associations with cylindromas, peyradinomas, which risk degenerating into carcinomas, epidermoid cysts, and milia. Brooke-Fordyce disease or trichoepitheliomatosis is an autosomal dominant disorder. Patients develop numerous papular lesions of varying size, predominantly on the face, and particularly the nasal and perinasal region. The management of multiple trichoepitheliomas is challenging. Indeed, it's a rare disease and the literature is scarce. There are no large comparative studies between the different therapeutic methods. Surgery, electrocautery, cryotherapy are invasive and present a risk of scarring. Radiotherapy is not invasive but presents a subsequent risk of development of malignant tumors. Laser treatments have been reported through small series and case reports. Regarding the CO2 laser, the first clinical trial was done in 1984, including 3 women with multiple trichoepitheliomas treated with power ranging from 10 to 100 watts in a single session. Slight atrophic scars were observed in 2 patients. No recurrence was observed up to 10 to 12 months of follow-up for the first 2 patients. The third was only seen after 6 weeks. In 1984, William and Auld reported a case of a 46-year-old woman with multiple trichoepitheliomas with involvement of the external auditory canal. She had a single session of CO2 laser with no recurrence at 8 months at the cost of minimal scarring. In 2007, a series of 8 cases published in the International Journal of Dermatology concluded that there was no significant reduction in the number of lesions in the 8 cases after just 1 CO2 laser session. Finally, a case report in 2017 published in Dermatologic Therapy highlighted the interest of the association of topical sirolimus after the laser session to reduce the risk of recurrence. Regarding erbium YAG laser, in 2005, a case of a 42-year-old woman was reported. She was treated with 3 sessions at 3 and 4 months intervals with the combination of erbium YAG and CO2 with good results and no recurrence after 2 years. The authors concluded that erbium YAG laser ablates the tumor tissues with minimal thermal effects and that CO2 achieves a good hemostasis, hence the benefit of this combination. In 2011, a comparative split-phase study in a 49-year-old man showed an interest in combining erbium YAG laser and photodynamic therapy for the treatment of multiple trichoepitheliomas. Finally, a case report of a 28-year-old woman treated with a single erbium YAG laser session was reported in 2020. She did not present any complications and there was no recurrence after 31 months. To conclude, the rarity of multiple trichoepitheliomatosis explain the poverty of the literature. Lasers seem to have fewer side effects and recurrences than other ablative techniques. The benefit-risk balance must be carefully weighed before considering this treatment. Larger-scale studies will be helpful for the choice of the most appropriate treatment. And thank you for your attention.
Bonjour tout le monde. Je remercie mon ami Brahim Traoré de m'inviter pour la énième fois maintenant pour présenter dans ce magnifique congrès virtuel de la Guinée équatoriale. Et cette fois-ci, je vais vous parler de la kéloïde de l'obé doré, comment briser cet iceberg. C'est vrai qu'il y a une vraie demande, un vrai besoin de traitement des cicatrices. Et soit des cicatrices post-chirurgicales, au post-brûlure, post-accident de la voie publique, au post-agression, au post-inflammatoire, au post-piercing. Nous sommes tous donc concernés par la gestion du process de la cicatrisation et le défect qui s'ensuit. Les patients porteurs de cicatrices souffrent, et nous savons tous ça. Ils souffrent énormément et les caractéristiques d'une cicatrice post-acte chirurgicale influencent fortement le jugement du patient sur la qualité du traitement reçu. Dans le meilleur des cas, le traitement préventif des cicatrices chirurgicales par des dispositifs à base d'énergie. Et ça, donc, c'est un traitement préventif. Mais l'acte chirurgical dans la kéloïde, la reprise chirurgicale, avec exérèse en bloc de la kéloïde est contre-indiqué. L'exérèse intrakéloïdien pour réduire la taille de la kéloïde a ses adeptes. Par contre, le cas particulier pour la kéloïde de l'oreille, on va en parler aujourd'hui. Donc, l'exérèse chirurgicale seule, il faut proscrire cette technique. Voilà, la kéloïde du lobule post-piercing, c'est une kéloïde qu'on voit fréquemment maintenant, surtout le développement des piercings. De plus en plus, il y a des piercings ben, c'est la mode, ou bien dans certaines cultures, le piercing, il est toujours là. Donc, le piercing post du lobule de l'oreille, ça donne fréquemment des kéloïdes. Et ce genre de kéloïdes sont difficiles à gérer. Traiter la kéloïde de lobule de l'oreille, il faut savoir combiner les méthodes. Première étape, il y a plusieurs étapes, le protocole. La première étape, c'est faire une exérèse transfixiante. La deuxième étape, à J3, on infiltre de la toxine botulique. Et l'étape 3, à J10, J15, on fait du laser fractionnel avec infiltration de corticoïdes de retard et l'ablation des points. Et puis la quatrième étape, c'est la pressothérapie, et cette pressothérapie qui dure jusqu'à 2 ans. L'étape 5, c'est un suivi sur 2 ans, avec des corticoïdes de retard chaque 1 à 2 mois. Donc il y a toutes ces étapes à respecter et une combiner toutes ces méthodes qui va pouvoir nous donner un bon résultat. Je ne dis pas toujours un excellent résultat, mais souvent un bon résultat. La première, c'est l'exérèse transfixiante sablier. L'exérèse transfixiante sablier, comme vous le voyez ici, donc vous avez toute la kéloïde qui est prise donc d'avant en arrière. Donc on prend tout le tissu kéloïdien et ne pas faire de shaving, surtout ne pas faire de shaving. Il faut prendre toute la kéloïde, donc transfixer le lobule. Ici, vous avez 2 kéloïdes, donc une ici et là. On a fait une exérèse transfixion des 2 kéloïdes. Puis, dans cette étape chirurgicale, tout sur la première étape, on va faire une suture dans le sens vertical en avant, et en horizontal en postérieur. C'est-à-dire, l'essentiel, c'est de pouvoir préserver cet aspect arqué du lobule. Et ça, il faut que d'un côté, c'est vertical, la suture, et de l'autre côté, elle est horizontale pour arrondir donc le lobule. Ensuite, l'étape 2, c'est à J3, on fait l'infiltration de la toxine botulique. Comme vous voyez sur cette vidéo, on va faire chaque 0,5 cm ou une unité, ou chaque 1 cm, 2 unités. Donc, essayez de ne pas de multiplier les unités, de répartir tout le long des berges, de 2 côtés des berges, sans pour autant le faire à J0. Pourquoi? Parce que vous risquez d'avoir la toxine botulique qui va sortir par la plaie. Donc, c'est pour ça qu'on préfère le faire à J3. La toxine botulique dans les cicatrices hypertrophiques, elle est connue depuis plusieurs années maintenant pour les cicatrices hypertrophiques. Et dans ce papier, ils ont fait une étude prospective chez 20 patients et qui présentent donc des cicatrices hypertrophiques de différentes parties du corps. Ils ont fait 3 traitements par toxine botulique, sont dépassés 100 unités par patient et par séance. Ils ont constaté une amélioration significative chez tous les patients à 6 mois avec un petit érythème irrité, un prurite et surtout une souplesse de la cicatrice. Donc, comme ici, vous le voyez, donc une cicatrice hypertrophique et qu'on injecte donc directement par la toxine botulique. Ce n'est pas du préventif, ça c'est du curatif, mais le préventif, comme je viens de le montrer tout à l'heure, c'est d'injecter donc une cicatrice déjà assez récente. Quel est le mécanisme suggéré? C'est de la toxine botulique sur la cicatrice hypertrophique. On parle d'un effet neuromodulateur probable sur le transforming factor et non pas sur l'immobilisation mécanique, comme c'est le cas au niveau du front. Donc, les preuves sont incomplètes, donc à suivre. Donc, on fait une ablation des points J10 ou J15, donc c'est l'étape 3, et le même jour ou le lendemain, on fait du fractionnel, un CO2 fractionnel, plus que c'est une séance qu'on fera à l'ablation des poids. On la répète une deuxième fois à J15. Donc, c'est 2 sessions, donc c'est pareil de 15 jours d'intervalle en post-opératoire, en mode chauffage, c'est-à-dire en faible puissance, comme vous le voyez ici, 10 watts et 3 millisecondes, donc en mode chauffage. Et ce temps d'exposition assez long va chauffer en profondeur et donner un bon remodelage. En fait, c'est une technique que nous avons technique que nous avons nous avons fait une étude que nous avons présentée en janvier 2019 dans l'association des dermatologistes libéraux tunisiens, cicatrice fraîche et laser CO2 fractionnel. Cicatrice fraîche, c'est-à-dire qu'elle est comme ici, par exemple, elle a deux lasers fractionnels à 15 jours d'intervalle. Vous voyez le résultat à 2 ans. Donc, c'est une prévention par les dispositifs à base d'énergie. 4 ans plus tard, cette cicatrice fraîche d'une mammectomie, d'une réparation, d'une mammectomie post-néo du sein, vous voyez donc une très belle qualité de cicatrice. Donc, avoir à l'esprit donc de traiter par les DBE les cicatrices chirurgicales fraîches. Démarrer une pressothérapie dans l'étape 4, c'est démarrer la pressothérapie à J15 ou J10, après avoir fait du fractionnel, bien sûr, le lendemain du fractionnel, avec la pressothérapie par des clips. Moi, j'utilise tout simplement des faux bijoux, hein, des faux bijoux. Mais vous pouvez aussi acquérir ce genre de clip sur des sites comme ici, airpress.com. Ça coûte un peu cher, 50 à 100 dollars le clip. Personnellement, j'utilise donc des faux bijoux, mais sauf que j'enlève cette partie de silicone, ce petit élément-là, de silicone, je l'enlève, vous le voyez ici, et je le remplace par celui-là pour ce qu'on appelle un répartiteur de pression. Il va mieux répartir la pression sur tout le lobule. Donc, ici, c'est une kéloïde donc, du lobule, exerce transfixion en sablier, même patiente, mais de l'autre côté. On a fait les différentes étapes, on a combiné la toxine, le fractionnel et puis la pressothérapie. Donc, regardez le résultat à 2 ans. Donc, on a un bon résultat à 2 ans et grâce à cette combinaison de méthodes. Le kéloïde ici, le deuxième cas clinique, c'est un kéloïde de l'hélix post-piercing. C'est une patiente de 18 ans qui a un kéloïde de l'hélix de l'oreille gauche en chou-fleur de 2 cm de grande taille, post-piercing il y a 2 ans. Opérée une première fois il y a 1 an, un shaving tout simplement, mais elle a récidivé rapidement. Donc, j'ai fait une exérèse cunéiforme de la lésion. Donc, j'ai emporté tout le dessus kéloïdien. Et puis, bien sûr, le tralala, de la toxine botulique à J3, fractionnelle à J15 à J30, corticoïde de retard chaque 1 à 2 mois, crème cicatrisante et pressothérapie à partir de J15 et pendant 2 ans. Donc, là, la post-opératoire est suivie, bien sûr, sur 2 ans. Et cette kéloïde, regardez l'évolution en 7 mois. Donc, comme vous le voyez ici, 7 mois, un excellent résultat. Et puis, à 1 an, on a toujours gardé le bon résultat. À 2 ans, bien sûr, oui, donc l'évolution est excellente. Et c'est souple. Donc, cette combinaison de méthodes nous a permis d'obtenir ce résultat. C'est un résultat, j'espère, durable pour le moment. Je crois qu'il faut continuer à contrôler la patiente au moins 1 fois par an, ou bien demander la patiente de faire l'autocontrôle s'il se développe une petite infiltration, c'est de venir me consulter. Mais je pense que Une évolution jusqu'à une surveillance jusqu'à 2 ans est largement suffisante pour dire que le résultat est bon. Faut-il masser les cicatrices? Dans un premier temps, une fois que la cicatrice ne soigne plus un aspect bien fermé, on masse doucement afin d'assouplir et d'éviter des adhérences profondes. 5 minutes matin et soir, en faisant des petits massages circulaires avec une crème cicatrisante, jusqu'à ce que la cicatrice soit souple et lisse, et ceci pendant plusieurs mois. Troisième cas clinique, kéloïde des deux oreilles qui ont récidivé. Opéré une première fois il y a 2 ans, sans combinaison de méthodes, oreille droite, oreille gauche, comme vous voyez ici, oreille droite et oreille gauche, sans combinaison de méthodes et sans pressothérapie. Donc, l'oreille gauche, à 3 mois après combinaison des méthodes, vous avez donc déjà, ça commence à avoir un bon résultat, mais ce n'est pas suffisant, il faut continuer à la suivre. Bien sûr, après avoir fait une exercice total du cycle hyloïdien. L'oreille droite aussi, exercice total et réparation, donc les deux, donc gauche et droite. Et vous avez donc ici une évolution à 5 mois. Donc, on n'a pas encore de récidive, mais il faut continuer la surveillance. On ne peut parler de guérison qu'après 2 ans. Le quatrième cas clinique, c'est une kéloïde de l'antélix post-accident de la voie publique. C'est un jeune homme donc, qui a eu cette kéloïde de l'antélix. Et vous voyez donc le tissu kéloïdien, il est en postérieur et en antérieur. Donc, on l'a opéré et on a transfixé le cartilage carrément, donc, pour pouvoir enlever une partie du cartilage parce que le tissu kéloïdien traversait le cartilage. Un mois après, donc, vous voyez qu'elle a un bon résultat. Il a utilisé des clips de pressothérapie qu'il a acheté donc, sur le net. Et 2 ans après, nous avons un bon résultat esthétique. Et puis, bon, il garde bien sûr une petite atrophie par les corticoïdes, par les corticoïdes retard que nous avons injectés pendant plusieurs mois. Il y a certaines erreurs à ne pas faire. Premièrement, la première erreur, c'est juste opérer. Ça, il faut éviter de faire ça. La deuxième erreur, c'est faire un shaving de la tumeur et de ne pas faire une exérèse totale de la tumeur qui est de du lobule de l'oreille. La troisième erreur, c'est la pressothérapie trop précoce, post-opératoire immédiate. Puis la quatrième erreur, omettre de combiner les techniques. Donc, il faut absolument combiner les méthodes. Cette patiente qui a un kéloïde de l'antélix, son dermato lui avait indiqué une combinaison de méthodes, mais son oreille l'opère, sans plus. Il la confie de nouveau à son dermato pour traitement par laser. Que faire devant cette encoche? La réopérer, faire que du laser fractionnel, crème cicatrisante, s'abstenir. En fin de compte, on a opté pour faire 2 séances de laser fractionnel. On a fait 2 séances de laser fractionnel et donc on a obtenu ce résultat, comme vous le voyez ici. Bon, ça reste à suivre. La pressothérapie, immédiatement après intervention, c'est la deuxième erreur à ne pas faire. Et cette patiente, elle a entendu parler de la pressothérapie, elle dit pourquoi pas ne pas mettre une pince à linge et regarder le résultat obtenu. Donc une nécrose, qu'on était obligé donc de faire une détertion de cette nécrose, de raviver la plaie et de suturer de nouveau. La troisième erreur à ne pas faire, c'est l'exérèse itérative sans combinaison de méthodes. Comme ici, cette patiente, elle a plein d'exérèses. Regardez, les kéloïdes, elles sont c'est monstrueux. Donc, vraiment, c'est la deuxième patiente qui a été opérée à 7 reprises de côté, a été greffée aux 2 oreilles, avec prise de greffe en prétrasien. Par ailleurs, multiples kéloïdes du corps dont certains ont été repris chirurgicalement. Je crois qu'il faut arrêter ces actes opératoires. Moi, je pense que c'est un peu trop abusif. Et donc, ces 4 erreurs donc, à éviter, ne pas opérer seulement, ne pas oublier de combiner les méthodes, ne pas faire de pressothérapie trop tôt, et puis surtout, il faut faire un bon suivi voilà, à plusieurs mois, voire des années. Alors, avec quoi on va partir? Quelle idée reçue? C'est de faire, c'est que nous savons tous maintenant que les keloïdes de l'oreille, il y en a plein. Par cause des piercings qui deviennent un effet mode, ou bien parce que tout simplement, il y a ceux qui mettent des boucles d'oreilles c'est-à-dire dans c'est culturel. Et la kéloïde, donc, c'est un problème épineux. Psychologiquement, c'est très douloureux pour les patients. Il y a un regard méchant de la société. Il faut apprendre toujours, je dirais bien, à lire avant d'écrire. Ça veut dire quoi? Bien examiner, apprécier exactement ce qu'on doit faire et qu'est-ce qu'il faut expliquer aux patients, exactement ce qu'on va faire et la durée, surtout, la durée du suivi. Il faut leur dire que c'est un suivi lent. Si la patiente ne peut pas faire un suivi lent, c'est pas la peine de la prendre en charge, de commencer à l'opérer. Et puis, savoir surtout, comme je disais tout à l'heure, combiner les méthodes. Avant de conclure, je vous invite au 6th Annual Meeting FLP Expert qui se déroule le 24 mai 2025 à Casablanca. Et puis, je vous remercie pour votre attention et j'espère vous revoir aussi l'année prochaine. Et je serai à votre disposition lors de la discussion, bien sûr. Je répondrai à toutes vos questions. Merci beaucoup et bonne fin de congrès.
Bonjour tout le monde, je suis heureuse de me trouver parmi vous et je remercie fortement mon ami Brahima Traoré pour cette invitation. Je vais vous présenter un nouveau traitement des kéloïdes. En fait, les cicatrices kéloïdes sont des cicatrices multifactorielles. Elles sont des tumeurs bénignes fibroépithéliales qui apparaissent chez des personnes prédisposées et elles représentent un motif fréquent en dermatologie. Elles siègent électivement au niveau des épaules, de la poitrine, des lobules des oreilles, des bras et des joues. Elles sont le plus souvent asymptomatiques, mais peuvent être associées à un bruit ou à des douleurs. L'impact de ces tumeurs cutanées est important, aussi bien social que psychologique. Ces lésions sont le plus souvent secondaires à des traumatismes, une inflammation, une chirurgie ou à des brûlures, bien que les cas spontanés ne sont pas rares. Commençons par notre premier notre premier patient qui a bénéficié de ce nouveau traitement. Il s'agissait d'un homme de 46 ans, de phototype 4, sans antécédents pathologiques particuliers. Il a été victime d'une brûlure thermique au niveau de la cuisse droite en 2007 lors d'un accident domestique. Cette brûlure s'est compliquée d'une cicatrice kéloïde. Il a bénéficié de dermocorticoïdes, de plusieurs séances d'infiltration de corticoïdes, de plusieurs séances de radiothérapie sans amélioration, jusqu'à 2009. Et il décrit toujours une douleur membre inférieur, un prurite, une extension de sa kéloïde et une gêne esthétique importante. À l'examen, on trouvait une kéloïde de 5,1 cm avec une forme géographique, une bordure irrégulière et une consistance dure. En fait, en cette période, on a commencé à réfléchir à propos d'un nouveau traitement pour les kéloïdes. On a vu le phénol, ses propriétés physico-chimiques, on a fait des recherches bibliographiques et on a essayé avec nos amis des pharmaciens à réaliser une formulation qui s'adapte à cette indication. On a eu la possibilité de proposer un nouveau traitement, un nouveau protocole, et on a obtenu le consentement de ce malade. C'est en 2010 qu'on a commencé le traitement. En fait, pour des raisons éthiques, on a obtenu l'approbation du comité de protection de personnes du Sud tunisien. Le protocole de ce traitement était réalisé au niveau du bloc opératoire du service de dermatologie. On a sélectionné des kéloïdes qui évoluent depuis plus qu'une année avec une surface inférieure à 900 cm², soit 30 x 30 cm. Ayant ou pas bénéficié de traitements antérieurs, et le traitement consistait à une application de 3 minutes les 2 premières séances, puis 5 minutes d'une façon hebdomadaire. On a opté pour une neutralisation du phénol, l'application d'une crème hydratante sans pansement associé. Voilà notre premier patient au cours des séances qu'il a bénéficié, un blanchiment de la lésion, une nécrose superficielle, des croûtes qui vont se détacher. Voilà à partir des séances, à la 5e séance, la 24e séance avec réduction de l'épaisseur, la 44e séance, et c'est la fin du traitement, avec un recul après 6 ans. Pour notre traitement, on a obtenu un brevet d'invention. On a publié nos résultats dans des revues bien connues et on a réalisé 2 thèses de doctorat en médecine à 10 ans d'intervalle avec un nombre qui a augmenté énormément de recensement de malades qui ont bénéficié de ce traitement. En guise de discussion, les lésions des kéloïdes sont des lésions cutanées bénignes purement dermatologiques, caractérisées par un envahissement des berges saines et une extension au-delà de la lésion initiale. Il est bien reconnu qu'on incrimine des facteurs génétiques, éthiques, moléculaires et mécaniques. La symptomatologie, elle est gênante, recalcitrante et elle imprègne le vécu de patients, surtout sur le plan psychologique. Voilà différents aspects des kéloïdes. L'indication du phénol dans le traitement des kéloïdes est inspirée des anciennes publications scientifiques traitant l'effet du phénol sur la peau. Le phénol étant lipophile et pénètre rapidement dans la peau avec un pourcentage de 60 à 90%. Le protocole de notre traitement consistait à une désinfection par badigeonnage et par du sérum physio, puis un assèchement, une application de la solution par un coton-tige égoutté, donc pour limiter l'application stricte à la kéloïde et respect de la peau saine. On fait un léger frottement pour permettre la pénétration du produit, une séance qui dure 5 minutes d'une façon hebdomadaire, en badigeant par la suite par du sérum physiologique et une application d'une crème hydratante sans pansement. Après cette séance, on va avoir un blanchiment qui est constant, immédiat et transitoire qui s'estompe en 10 à 15 minutes et une rougeur qui peut persister 2 à 3 heures. Voilà le blanchiment des kéloïdes. Voilà, une de nos patientes qui a bénéficié de 20 sessions pour cette kéloïde post-accident de la voie publique, pour laquelle elle a bénéficié de plusieurs séances de radiothérapie. Une autre patiente avec cette double localisation des kéloïdes, une régression importante. D'ailleurs, la patiente était gênée même par le port de certains vêtements. Donc, l'aplatissement de la lésion de sa kéloïde était d'un apport important, surtout psychologique pour la patiente. Une autre lésion au niveau de la région occipitale et on bénéficie de 8 séances. Les lésions de l'obus de l'oreille étaient fréquentes. Voilà une réduction de la taille, d'épaisseur après séance d'application de phénol. D'autres lésions, aussi bien au niveau du corps chevelu, au niveau du lobule de l'oreille, au niveau de l'avant-bras. Les lésions de chirurgie thyroïdienne sont fréquentes et une lésion du dos et on bénéficie de 23 lésions avec réduction de l'épaisseur de la kéloïde. D'autres aspects, lésion du cou, la région pubienne et une lésion sternale aussi. Une lésion de la main, réduction de l'épaisseur et une lésion kéloïde post-brûlure avec une réduction de l'épaisseur énorme. Lésion occipitale aussi, une autre lésion sternale. Si on compare le phénol aux autres lésions, aux autres moyens thérapeutiques, on va voir si les lésions de corticoïdes intralésionnelles peuvent avoir une efficacité de 40 à 70%, alors qu'une récurrence à 5 ans est de 10 à 50%. La chirurgie seule peut avoir une récurrence ou une récidive dans 100% des cas. Le phénol, quant à lui, aura une efficacité dans pratiquement 90% des cas et on n'a noté aucune récurrence ou aucune récidive de la kéloïde. Les effets secondaires du phénol appliqués sur paroi locale systémiques sont pratiquement inexistants. Les quelques lésions, quelques effets secondaires locaux ont été notés, surtout une pigmentation post-inflammatoire, une dyschromie, des grains de millions, parfois un érythème ou une infection. En conclusion, la phénolisation est un traitement innovateur et prometteur. La régression est de plus de 60% de la cicatrice dans 85% des cas, avec un taux de récidive médian de pratiquement 90% des cas. Près d'un quart des patients ont obtenu une disparition de la totalité de la lésion kéloïde et le pourcentage de régression sous phénol d'une kéloïde post-brûlure paraît intéressante, la plus répantrice à les cicatrices kéloïdes post-brûlure qui répondent très bien au phénol, qui peut atteindre même 87% des cas. D'ailleurs, le phénol paraît bien toléré sur le plan général. Aussi, les lésions locales sont minimes, parfois le plus souvent transitoires, donnant un caractère rassurant à ce traitement. Et la phénolisation présente plusieurs avantages, notamment la simplicité d'application, le faible coût, une sécurité d'utilisation, une bonne tolérance, un pourcentage important de régression et l'absence de récidive. Les principaux facteurs limitants sont le nombre élevé de séances et la survenue d'effets secondaires, bien que ils sont transitoires et minimes. Donc, le phénol paraît être un nouveau traitement des kéloïdes, d'autant plus qu'il a un coût assez faible. Je vous remercie de votre attention.
I'm professor of dermatology in Algeria, Oran. I'm discussing about top news lasers. In this first, for hair removal. The first study is about a randomized clinical trial monitored from September 2017 to September 2022. We saw more than 300 patients aged from 11 to 21 years old with pilonidal cyst. And we create two groups. First group, we treated with a standard treatment. And the second group, we use standard treatment and hair removal laser. We used diode and alexandrite, and some cases, the most cases, we used Pandeya. We saw that the recurrence in the first year interval was significantly lower in group laser, group 2, with P very, very important. So the conclusion of this study is that the hair removal should be considered as a modality of a standard treatment. Second study, objectives to identify the causes of paradoxical hair regrowth. So the methods, we saw more than 7,381 patients treated from November 2018 to November 2020. By alexandrite, 70% of patients, and diode, 30%. The results? We saw 25 PHR, so 0.34% of all the patients. The most patient, 24 from 25 PHR treatment was about alexandrite with significant P. The first area is the upper of arm. Second area is the periareolar. Sun protection significantly reduced the risk of this PHR with significant P, independent of phototype, also with the significant P. The conclusion of the study was that there is no differences linked to phototype. High risk factors are area, arms, periareolar. The factors for low risk of PHR was photoprotection, and diode was associated with significant reductions in PIH incidence. Vascular. This study target was to compare the effectiveness and safety of PDL to IPL with three spectral bands, broad, narrow, and double narrow band, in the treatment of erythematous telangiectasia rosacea. Protocol: we choose 60 patients randomly divided into 4 groups and received one of the treatment, PDL 595 nanometer, IPL 500 to 600 nanometer, IPL with M22 protocol 590 nanometer to 1200 nanometer, or IPL with M22 vascular filter with double narrow band 530 to 650 nanometer and 900 to 1200 nanometer. We did 4 sessions, 4 weeks apart, with follow-up 4 weeks after the final sessions. Assessment: clinical, side effect, pain, purpura, edema, erythema, and burns. VISIA score and ROSA-COL score before and after treatment. Results: significant improvement in scores in all 4 groups with significant P. Burns were higher in the M22 vascular group. Second study about vascular. The aim of this study is the first-line PDL treatment for port wine stain, but maintenance costs, it's so higher. So it's the first study about maintenance costs. The methods: prospective, randomized, double-blind, split-sided study. We compare KTP to PDL, 5 sessions spaced from 6 to 8 weeks apart. Follow-up 6 weeks after the treatment. Evaluation by 2 blind investigators with colorimetric, surface reduction, satisfaction of patients, and side effects. And also maintenance issues. Results and the conclusion that there is no significant difference between KTP and PDL, with the side effect that KTP laser 532 nanometer caused less edema, purpura, and scabs. Patients were satisfied with both lasers. PDLs malfunctions for more than 6 months, a year. No failures with. Third study. The target of this third study is to evaluate the effectiveness of 595 nanometer PDL and 1565 nanometer non-ablative fractional laser for treatment of erythematous acne scars. Methods: we choose 90 patients divided equally into 2 groups. Group A, we did an NFL number 45 patients. Group B, PDL with fractional non-ablative laser. Results: the erythema regression rate of Group B was significantly higher than Group A, with P under than 0.001. So the association between PDL and non-ablative fractional laser are better than to use each one alone. The result and the conclusion was that clinical improvement at 4 months after the treatment with a significant increase in expert panel evaluation scores. Patient satisfaction is significantly improved and less minimal side effects. The conclusion that this technique is very interesting in the androgenic alopecia. Second study, treatment of melasma by pico-alexandrite compared to Kuswitch-Yag. Methods, it's a randomized and controlled study over 2 years in split phase. Treatment by Pico compared to Kuswitch 1 month apart. Monitored by MSC, side effect, pain scores, patient satisfaction, and in vivo confocal microscopy. Very interesting. Result at 6 months, significant reduction in MSC initial values for the Kuswitch sides. No improvement at the beginning of the fractional picosecond laser side. No serious side effects were reported. Less Kuswitch-Yag pain. And in picosides, we saw in microscopy, confocal microscopy showed large numbers of dendritic melanocytes infiltrated in the dermis 2 weeks and 4 weeks after treatment. Recurrence or exacerbation around 60% of patients at 2 years on both sides, Pico and Kuswitch. The conclusion that was Kuswitch-Yag has short-term clinical effectiveness than Pico. Kuswitch was associated with less pain. Recurrence after 2 years in high in both. 2 groups. Fractional and ablative. What is the top news this year? This study showed that an extensive research was conducted using PubMed, focusing on laser treatment for melanoma until this year. The conclusion that the traditional treatments remain the standard for primary melanoma, but the ablative CO2 laser is very promising in palliative care. For example, in transit meta. Second study is to evaluate the safety and effectiveness of fractional ablative CO2 in patient concurrently treated with isotretinoin. Methods, it's prospective split-sided randomized controlled trial with fractional ablative CO2 at the same time with isotretinoin compared to fractional CO2, ablative CO2, 6 months after stopping the isotretinoin. The conclusion was that the concomitant treatment with fractional ablative CO2 laser associated in the same time with isotretinoin is safe and it's superior to delayed fractional CO2 treatment 6 months after stopping the isotretinoin. So there is no danger with CO2 and fractional CO2 and isotretinoin. Fractionals also laser and LAD. It means that we deliver drugs by laser. This first study is about fractional CO2 laser in combination with topical aqueous triamcinolone, corticosteroid intralesional in monotherapy and alopecia areata. The conclusion of this study that showed that fractional CO2 associated with dermocorticoid is better treatment modality than triamcinolone acetonoid intralesional injection for the treatment of alopecia areata. So to associate a topical dermocorticoid corticosteroid is better, and we have less side effect than the injection of corticosteroid in intralesional alopecia areata. This study was interested of the ablative fractional CO2 laser in increasing drug delivery in nail psoriasis. We did research in PubMed, Medline, Embase, Cochrane, Systemic Review until July 2023. We saw 7 randomized controlled trials with fractional CO2 laser and topical treatment for nail psoriasis. And the key messages was that there is less pain with association of topical anesthesia, and the side effects we saw erythema, some cases edema and clots, little cases about Koebner phenomenon, and consistently high levels of patient improvement. And at the end of at the beginning, of this month, June, we saw a new study about using CO2, fractional CO2 in psoriasis nail, and we add methotrexate in topical treatment, and we saw that there is very good improvement. Fourth study, the objective is to compare the treatment effectiveness of localized stable vitiligo by Group A topical Loprost alone compared to this treatment with fractional CO2 associated with CO2 and compared also with the group C with topical treatment, fractional CO2, and PRP. We did a biopsy before treatment and 4 months after the start of the study. Conclusion was that the fractional CO2 associated with PRP improves the therapeutic effectiveness of latanoprost 0.005% in the treatment of. Merci. You can ask the question if you want, and I will receive it by mail, and then I will answer. Thank you.
Hello, my name is Dr. Patrick Tracy. I'm an aesthetic physician from Dublin in Ireland, and I'd like to welcome everybody around the world to the first global virtual aesthetic summit. This is a wonderful idea, and for all of us that are just joining aesthetic medicine recently and seeing the problems, particularly with delayed onset nodules or also vascular occlusions, let me tell you that since 1999, I've been dealing with these and other problems of a much bigger scale. So what I'd like to do, I suppose, in this lecture is to take us back over the last 20 years of dealing with aesthetic complications. This is a very interesting photograph. This was taken at the Royal Society of Medicine recently, where I was chairman of the Congress. And you can see two of the people in this photograph have got hemifacial autologous transplants. This lady, you can see with her cheek, and this lady with her forehead. And I'll go into that in a moment. So this is my biography. Over the last 3 years, I've won, I suppose, a lot of awards and medals in aesthetic medicine. And we can pass on through that to 20 years history of complications. Where are we now? Hyaluronic acid fillers. So as a consequence, because I'm dealing with complications, I'll sort of mention them. This is one of my own patients, and this patient here got fillers 1 week before she got married, and she had an allergic reaction, and as a consequence, she just got some steroids, and it had cleared up within 48 hours. This is a patient I've seen very recently. She was sent to my clinic with this type of reaction, and even though you see these pictures posted all over the papers, this is quite easy to treat. It's a hypersensitivity reaction. This patient had angioneuritic edema as well, so in her history. So I thought it was preferable to give her some adrenaline as well as some steroids. And by the time she'd reached home, which is about 3 hours from Dublin, her problem had cleared up. Again, I don't want to mention compounds, but I suppose I have to an extent, because these were the problems that we had, and these are the problems we grew up with. This patient here had granulomas in her face. I don't want to stay on our images for too long, because I'm aware that this is an aesthetic summit that can be picked up on mobile phones. And her granulomas had to be treated. Now, the polylactic acids, unfortunately, if you put them into circular muscles, then they could precipitate out crystals. And this caused a lot of problems at the time. Next patient was from Spain. And at this time, back in 2001, the world was facing a crisis with HIV, that it still is, but I suppose less focus has been put on it by the newspapers. And at that time, I suppose, the only treatment for HIV lipoatrophy, and we didn't know at that stage whether it was going to be as a consequence of patients living that long with their illness, or whether it was secondary to the side effects of the medicine. So I'll just run into a little bit of the history of the time. At the time, you can see that I was writing sort of some articles on HIV, and if anybody reads my memoir, they will see my particular interest in that disease, particularly in Africa. So we were treating the patients with HIV lipoatrophy with Sculptor or the polylactic acids. But we had three big problems. The first thing is that we couldn't trust the medical reports that we were getting in from different countries. They were all saying it was the CD4 level was fine and that the viral load was negligible. that they weren't infectious. But the second problem, of course, was that to do Sculptra at the time, they needed 5 treatments. And the third thing was because, as anybody that has used Sculptra knows, the needle stopped blocking all the time. So you increased your risk of a needle stick injury from HIV dramatically. These patients needed up to 100 injections within the dermal layer. And as a consequence, we had to come up with a new way of doing it because at the time there was recognized needle stick injuries, and we came up with bioalchemate. Bioalchemate was a product of the period, and we treated HIV lateral atrophy. I've had to reduce. I include this only because this is Dr. Alex Catino, who is head of the task force in Africa for HIV from Makerere University in Kampala in Uganda. And Bono had gave him the United Nations Humanitarian Award for his work in Africa. And I got to know Alex at that time. And because we were seeing so many HIV lateral atrophy, I really wondered, was it the drug or was it a progression of the disease? So at the time, I had looked at Alex's work, and this is some contact we had together back now 14, 15 years ago. And so when I went down to Uganda, I realized that the patients I was seeing there didn't have this condition. It was very much a Western condition. So I presumed, or I advocated at the time, that it probably was the drugs that was causing it. It was later proven, probably about 2006, 2007, that it was the peroxide radicals of the antiretrovirals. And as a consequence of that, new drugs came out which didn't cause that transposition of fat. But at the time, it was a big period problem for us. This is the first patient I treated in the United States with bioalchemate. A wonderful guy. He went on a cruise liner after that. He'd been socially isolated in a room for 4 years. And I believe he may have even got married in that period, but I'll sort of move on. So this is a paper I wrote in the British Journal of the Journal of Dermsurgery at the time, where we had taken, I can't remember at the time, maybe 11 subjects with HIV, and I wrote a paper on bioalchemate, and it made it so easy because you could treat the patient in 1 day, the compound lasted for life, and the patient didn't have to come back, but life wasn't all that easy. As you know, the next problem we had, that bioalchemate started causing sterile facial abscesses, quite dramatically actually, and some of the patients we didn't see until 10 years later. The compound has now been taken off the market, particularly after the Canadian board had made complaints against the company. So this is one of the patients, and this is the way I suppose we could treat them. So when the compound presented, it presented like this, and you can see when you point it, you can see there's white, and just nicked it, and the product came out. So we had so many of these patients to treat in this period, particularly.
So the level of bioalchemate from the face, you can see that it's usually only the skin, and it's easy.
So then I was invited to Moscow as one of the first, I suppose, lectures back in after communism had ended. And when I was there, I was lecturing on that period where we had fibroblast transplants under Esologen, another compound that has been pulled off the market. And at the time, I noticed that we were having a lot of doctors coming to me with problems with bioalchemate, Aquamid, and also we went through this period of nodules in people's lips, 2004, and so there was quite a lot of these, including infections. So just because people are seeing now all these problems with lips, believe it, we had it 15 years ago, if not 20 years ago, and you can see lots of different things. Again, I wrote a paper on this, advocating that polyvinyl should not be used in lips, and I wrote up again some papers on this. Now, At the time also, I noticed that Radiesse was causing problems in lips. Particularly, and I advocated that maybe it should not be used in the perioral area at all, particularly the perioral commissures. So this is us in 2007 at the Seafield conference, where I advocated two things: the use of, I suppose, lidocaine with Radiesse because it was a painful compound, and also to not put it in the glabellar or in the perioral area that we're experiencing now. So case 10 was removal of hyaluronic acid. So nobody really had used hyaluronidase to remove it, but we were using it 15 years ago, back in 2005. And at the time, I had written protocols for hyalase, which are very important now. And this is a period, I suppose, where dermafillers were showing problems in patients, particularly if they went into the angular artery, the ilar artery, branch of the facial artery, all the way up, with a potential even in later years to cause blindness. So at the time, Arnie Klein, the late Arnie Klein, who is still alive, was treating Michael Jackson, the late Michael Jackson also, and he had put a little bit too much fillers in a face, and as a consequence, Michael needed it taken out. And I suppose most people know that he flew across the Atlantic and we had to take it out. I only mention him during the lecture because, believe it or not, he was one of the first patients in the world that hyaluronidase was ever used on. As well as that, when we contacted QMed at the time, who made the product involved, they had no protocols and they knew of nobody that had actually used it to reverse overfill of a hyaluronic acid filler. So after that, hyaluronic acid was used for breast implants, and this was a wonderful compound. You could actually do a breast in something like 10 minutes, and it would last, at the time, if I remember, up to about 18 months. I was using it for some more interesting things, like pectus excavatum, and you can see this patient here with, I suppose, the heart involved to an extent. You can see how it was, I suppose, moved within the thoracic cavity as a consequence of the pectus excavatum, and without letting the patient's pictures be seen, I was using it more medical than cosmetic at the time, but it caused its own problems. So then the vascular problem started, and particularly the vascular problem started because most of the fillers we were using were non-reversible. So this is a patient I don't want to harbor on them that I had seen at the beginning of this journey. And then I was writing a paper on using dermafillers for atrophic scarring, and this is a patient of my own. I had this little bleed. Within a small period of time, it had gone into this reticular pattern formation where you had hyperemia, and within a very short period of time, a few days, you could see this crusting, and this patient thankfully recovered totally. Possibly the transverse facial artery involved. Hello, my name is Dr. Patrick Tracy. I'm an aesthetic physician from Dublin in Ireland, and I'd like to welcome everybody around the world to the first global virtual aesthetic summit. This is a wonderful idea, and for all of us that are just joining aesthetic medicine recently and seeing the problems, particularly with delayed onset nodules or also vascular occlusions, let me tell you that since 1999, I've been dealing with these and other problems of a much bigger scale. So what I'd like to do, I suppose, in this lecture is to take us back over the last 20 years of dealing with aesthetic component. So this is my biography. Over the last 3 years, I've won, I suppose, a lot of awards and medals in aesthetic medicine, and we can pass on through that to 20 years history of complications. Where are we now? So then the vascular problem started, and particularly the vascular problem started because most of the fillers we were using were non-reversible. So this is a patient I don't want to harbor on them that I had seen at the beginning of this journey. And then I was writing a paper on using dermafillers for atrophic scarring, and this is a patient of my own. I had this little bleed. Within a small period of time, it had gone into this reticular pattern formation where you had hyperemia. And within a very short period of time, a few days, you could see this crusting in this. This patient thankfully recovered totally. Possibly the transverse facial artery involved by the distribution of the network. This is a friend of mine at the time. She was Julie Bass. Julie, if you're watching this, hi. I know she had a hard time in California with the fires recently. She was the first patient to allow photographs to go onto social media and the internet. And you can see that this area of her face was compromised. And Julie later met me in Dublin along with her lovely husband and her lovely family and husband. And thankfully, all is well now. This is a patient that I had seen myself, and I had written up hyaluronic acid. So this is one of the first papers in that period that had reversed vascular occlusion. And when we started writing the protocols, this is a patient from Chicago. I'll not dwell on it. That was involved. And again, I'll not labor on this, but this was the start of biofilms, which became a problem in that period. And this was testing dexamethasone against 5-fluorouracil, and you can see the one that happened there. This patient here was referred to me from one of the hospitals with gross biofilm in her face. I'll not stay on it too long, but it took me 3 months to clear that. And at the time, I had done 2 different things. The first thing is I'd used dexamethasone to break down the capsule. Second thing, I'd use inhalase to break down the compound underneath the capsule. And third thing, I advocated the use of antibiotics, Placid in this instance, and rifampicin. I treated the patient as if they had tuberculosis, maybe, from the point of view that it's encapsulated. The ordinary antibiotics can't work against the target microbe because it's protected. So we went in to break down the protections and with the highlights. And thankfully, maybe biofilm in that period was overrated a little bit. So then we had the problems of vascular occlusions involving blindness. And thankfully, Jean Carruthers and some of our other colleagues were able to highlight the cases around the world. This was an interesting patient. We seen her at the very beginning. Carl Byrne, and she had written to me, you see in that period. And Carl had got some silicone injected into her forehead, caused this gross reaction. And she was treated in the UCLA craniofacial unit by Riza Jari and another colleague of mine from Northern Ireland, and Dr. Brian Boyd. And you can see here that she got this face transplant, or facial, semi-facial transplant, autologous. And this is her with myself in the Royal Society of Medicine just a few months ago, actually. She flew over to London and then over to Ireland. And that goes to show you the sort of problems that existed, I suppose, during that period. Then I had developed a thing called the helper technique, where the patient presented with quite marked, I suppose, partial or impending necrosis of the area with sloughing, secondary to vascular occlusion. We put this patient in the hyperbaric oxygen chamber, and then I brought in this technique, I suppose, where we could use PRP. One of the problems I've always advocated with either burns or vascular occlusions is that the normal healing process cannot occur. As a consequence of no blood being there, then epidermal tissue can't form. And in one of my other lectures later on, I'll go into that. So we advocated the use of PRP in the patient. And one of the problems with PRP per se, of course, is that you get a very marked vascular, because one of the growth factors is the vascular fraction. And as a consequence of that, I knew that once I restored her epithelium, it was going to be quite vascular. So what we done was we dampened that down with IPL over a period of 3 treatments over 9 weeks. And then you can see that the tissue that formed was still with a lot of open pores and all the rest. So I used on that a CO2 laser, and she came out with no scar. We treated 8 patients subsequently with what I call the helper technique. So that was written up there. Then we had to form some protocols regarding hyaluronidase. So there was an expert panel in Las Vegas in 2011, and we came up with using probably hundreds of international units, particularly of hyaluronidase, up to 750 isodaplicate. This is a case I don't want to labor too long on. Came to me or through me from Sweden, and it was a patient who had developed monocular blindness as a consequence. What we thought at the time was some of the embolism occurring in the cavernous sinus rather than in the retinal artery. So at the time, this patient was receiving stem cells in Baltimore, or in Florida, but she was from Baltimore. This was a multiple sclerosis patient who potentially could get better anyway. It reminds me, in the Irish papers this morning, there's a case of, in one of our holy shrines, Knock, what they're putting down as a miracle. Again, a patient who had multiple sclerosis. These patients spontaneously go into remission. And so it doesn't really impress anybody medically, but to claim this as a consequence of stem cells, I believe the people involved have since had their license pulled. But at the time, I was also in South America, and I suppose I was with a stem cell expert, Alvaro Scupin, along with his wife, Nancy, who run a center in Florida and also the Dominican Republic. So we were going to send the patient there, but then the Caroline Institute had this problem with this doctor, Paolino Macchiarini, who was doing these esophageal transplants. I had seen Paolo in the Royal Society of Medicine. Unfortunately, his research didn't prove to be as valuable to medicine as we thought it was going to be. And some of his patients, I think, had died as a consequence. And Caroline Institute had sort of pulled. So that's a history of complications. Where are we going? We're going to look at that in one of our next lectures. So what I had done was, for one of the next lectures, is to look at the helper technique. And of course, the helper stood up for hyperbaric oxygen, epithelialization, Li light, P was the platelet-rich factors. And so what I decided to do was add in mesenchymal and stem cells to see can we get a better result. So certainly I will look at that in one of our other lectures.